Welcome to another Ultrasound of the Week. I'm Dr. Michael Schick. This week we have an infant presenting to your emergency department. The patient was a trauma transfer with an unknown mechanism. The patient was in respiratory distress at the outside hospital and was intubated and comes in that way to you. However, the patient has been hypoxic en route and is hypoxic in the high 70s when they arrive, but has symmetric breath sounds on auscultation. Now, this patient has no signs of infection, has no outer signs of chest wall trauma. Therefore, pneumonia or pulmonary contusions seem unlikely. The real things you're trying to decide between are pneumothorax or right mainstem intubation. And I know that auscultation with my stethoscope, especially in this age group, is not nearly good enough to rule out pneumothorax. So order a chest x-ray, but there is a role for point-of-care ultrasound. Think about your FAST exam. In the extended portion of that, you look at the lungs to rule out pneumothorax. Now you can do the same to evaluate for pneumothorax versus a right mainstem intubation. In this ultrasound, you can physically see the pleura in between the rib shadows, and this rules out a pneumothorax. And one of the telltale signs here is that you see a comet tail artifact, and that's going to tell you that the pleura is abutting the chest wall. The other thing to really notice about that comet tail artifact and about the pleura is that it's not really sliding back and forth. If you look at that comet tail artifact, it's pretty fixed in space. There is pulsatility to it, so it's kind of shivering back and forth a little bit, but that is something called the lung pulse. And literally, it's from the heart beating and the vascular flow going to the lung that makes the lung pulse, but there is no physical slide of the lung because this patient has a right mainstem intubation. And when you place the ultrasound probe on the right lung, you confirm that there is good sliding on that side.